Today, I would be reviewing psychopathology under the client needs category of psychosocial integrity, and I'll start with schizophrenia. Schizophrenia is a disorder that affects a person's ability to think, feel, and behave clearly. Again, the exact cause of schizophrenia isn't known, but like we said, it is characterized by thoughts or experiences that seem out of touch with reality. So what would you see in a client with schizophrenia? One obvious symptom or sign you would see in this client would be they would have a flat affect. With flat affect, people or the person cannot express emotions in the normal way that other people might express emotions. For example, when a normal person is happy, they may smile just to show that they are happy or they are pleased. But a person with flat affect shows no facial expression. You would also see delusions, which is a belief that is clearly false. They would also hallucinate. Hallucinations are sensory experiences that appear real, but are created by your mind. They can affect all five senses. For example, you might hear a voice that no one else in the room can hear, or see an image that isn't real. So these are false sensory perceptions in the absence of an actual external stimuli. It could be auditory, it could be visual, it could be olfactory, or it could be a tactile hallucination. They would also exhibit falsity of speech or thought. So in clients with serious mental illness, talking might be hard. So they will have this lack of conversation, which is called alogia or poverty of speech. They would also show signs of disorganized thinking. So a person engaged in disorganized speech might quickly jump from one unrelated topic to another. They could engage in incoherent word salad, repeat things another person says back to them. For example, you could see loose associations. What do we mean by loose association? Here, the patient will rapidly shift from one topic to another topic with no connection between one thought and the next. So you can hear them say, for example, the world turns as the world turns on a ball at the beach, but all the world's a stagecoach and I took the bus home. So you see this incoherent word salad, shifting from one topic to another with no connection between thoughts. You could also see neologisms. So these are made up words or phrases that only have meaning to that patient. You would also see perseveration. So here, they keep saying the same thing over and over again. What else can we see in this client? We could see hypochondriasis. So with hypochondriasis, there's this obsession with intense fear of having a serious condition. And they worry that any minor symptom might actually indicate something serious. So you see them switching doctors, they are Googling up their symptoms, reading up on what it might be. Again, you would also notice suspiciousness in these clients. So here they see the world as a hostile, threatening place. They feel like everybody's working against them. There's a plot to kill them. So you see that high suspiciousness in these clients. There would also be delusions, that persistent false belief. For example, the client might believe their stomach is missing. Again, delusions could also be in various forms. You could have grandiose delusion. So here, the person believes that they are special, or you can see this client thinks he's a Superman or something like that. So that's what we refer to as delusions of grandiosity. They could also exhibit persecutory delusion, where they feel that they are a victim of a plot. There could also be ideas of reference, where they believe that environmental effects are directed towards them or against them. So if the client sees people talking, they believe they are discussing the client. So that would be your persecutory delusion. Whereas with ideas of reference, real events that are internalized personally, that's what we refer to as ideas of reference. They are not based in reality. Schizophrenia could come in different forms. One of them would be paranoid schizophrenia. With paranoid schizophrenia, it's characterized by symptoms of schizophrenia, including delusions and hallucinations. So it's difficult for this person to lead a typical life. And some of the symptoms we would see would be ideas of persecution and delusion, like we mentioned. The most common would be delusions of persecution. Hallucinations is common. They usually involve hearing or seeing things that don't exist. They would have disorganized thought processes or thinking or speech. You would notice anger, or they could be hostile. And it usually has this late onset in life. There could also be catatonic schizophrenia. So this is a behavioral syndrome that is marked by an inability to move normally. Catatonia may involve symptoms such as staying still. So you can see how this patient is just standing in that awkward position. So that's what you see with catatonia. They could stay still for long periods, or they could have this fast pacing about movement or strange movements. They could even exhibit lack of speech or other unusual behavior. You can see this patient pacing in a repeated pattern or making loud exclamations for no reason at all. They could also exhibit parrot-like repetitions or echoing of words, which we call echolalia. So that echoing of words, that parrot-like repetition of words is also a common catatonic behavior. So like we said, you would notice they could have this rigidity or stupor that lasts for hours or even days in that same position, or they are performing strange movements, or they could be staying in uncomfortable positions without shifting, or erratic and extreme movements, or echolalia, those repetition of words or behaviors. Treatments would include medications like our lorazepam and diazepam. We might also need to carry out electroconvulsive therapy or ECT. Part of our plan would be to maintain client safety. And how do we want to do that? We want to protect the client from those altered thought processes, decrease stimuli, decrease sensory stimuli, remove them from areas of tension. So you want to recognize that this client is experiencing hallucination. So you don't want to go about arguing with this client. Don't respond to those feelings or tones of hallucinations or delusion. But again, you must be alert to hallucinations that command the client to harm themselves or others. We also want to protect the client from erratic and inappropriate behavior. When you communicate with these clients, communicate in a calm, authoritative tone. You want to address the clients by name and always observe for signs of escalating behaviors. Look out for those early signs of escalating behaviors. We also want to meet physical needs of this client, especially if they are severely regressed. Their hygiene, basic hygienes may be affected. So we might need to wash this client initially. We need to feed this client, especially if they are having poor nutritional habits. So you can assess the client, ask them, pick up a spoon. You want to find out if they are able to feed themselves. Are they able to make that decision? If not, then feeding would be necessary. When this client is ready, we can then encourage them to eat in a dining room with others. Remember, you don't want to force this patient into groups. They must be ready, and then we can encourage them to eat in the dining room with others. We also need to maintain a therapeutic relationship, engage in individual therapy, institute measures to promote trust. So you want to be consistent in keeping all scheduled appointments. You want to be seen as reliable. That would help to create that therapeutic relationship with your clients. You also want to avoid direct questioning. because that will make your client to feel threatened. You want to accept the client's indifference. For example, their failure to smile or even greet the nurse. Remember, we said they could suffer from this flat affect. So you want to accept that client's indifference and even their avoidance behavior. For example, hostility or sarcasm. You want to acknowledge all of that. And we would also discuss all staff changes, especially vacations and absences with the client. That's also going to help to build and establish a therapeutic relationship. You want to use the client's name in a calm and authoritative tone, like we mentioned, and then you must be able to tolerate silences, because you may have to sit through long silences with these clients, especially when they are too anxious to speak or when they are in that catatonic episode. So you want to accept regression as a normal part of treatment when new stresses are encountered. You want to engage the client in family therapy, engage in socialization or activity group therapy according to the client's ability. And if the client cannot tolerate group, do not force them to join the group. We also must provide simple activities or tasks that can help to promote positive self-esteem and successes to help them achieve some successes, no matter how little. For example, we can ask them to engage in finger painting and clay. These are good choices for regressed catatonic clients. So that's an example of finger painting with clay. You want to encourage attendance at occupational therapies and avoid competitive situations, especially with paranoid schizophrenic. You want to avoid competitive situations with paranoid schizophrenic. Solitary activities are much better for these clients. For these clients, we'll need to administer antipsychotic medications. For example, our haloperidol, which is a medication that works in the brain to treat schizophrenia, is a first-generation antipsychotic medication. What does haloperidol help us do? It helps us to rebalance the dopamine levels in the brain. That would automatically improve the client's thinking, his mood, and his behavior. Dopamine is actually one of the feel-good chemicals in the brain. For the NCLEX, you must take note that haloperidol can cause tardive dyskinesia. How do you identify tardive dyskinesia? You would notice repetitive, involuntary movements in your patient. For example, they keep grimacing their face or repetitive blinking of the eyes. And if they're on haloperidol, you want to start suspecting tardive dyskinesia. With bipolar disorder, this is a disorder that is associated with episodes of mood swings that range from depressive lows to manic highs. So again, with the manic episodes, you will see your client would have high energy. They will have that reduced need for sleep. They will lose touch with reality. And then when they are in the depressive episodes, you notice that they have low energy, low motivation, loss of interest in daily activities. So these mood episodes can last days to months at a time and may also be associated with suicidal thoughts. So again, with bipolar disorder, you notice episodes of mood swing from mania to depression. With mania, what do you see? There's this talking excessively, racing thoughts, hostility, less sleep, delusion. You see them, they are quick-tempered and agitated. They talk excessively, jokes, dances, sings. They are hyperactive. They can't stop moving to eat because they are easily stimulated by the environment. They have that decreased appetite. There's weight loss because they can't stop to eat. And there's insomnia. But in the depressive mode or depression episode, what do we notice? There's extreme fatigue. They have this prolonged sadness, memory loss, and even poor nutrition. What's our plan for these clients? One, we want to institute measures to deal with hyperactivity and the agitation that they're experiencing. We want to simplify the environment and decrease environmental stimuli. So you can assign them to a single room away from activity, keep the noise level low, very soft light in the room. You want to limit people that could trigger them. You also want to distract and redirect that excessive energy. For example, you can choose physical activities using large movements until the mania subsides. Example, dance. That would help to expend all of those energies. We can also provide external controls to help. Maybe assign one staff person to provide controls. Again, do not encourage the clients when they are telling jokes or they are performing. So you need to avoid laughing at their jokes. You also want to accompany the client to his room when hyperactivity is escalating, when they might be a threat to themselves or others. We want to move them to their rooms. We would also want to institute measures to deal with manipulativeness. So set limits. We can limit phone calls when excessive. We can set firm, consistent times for meeting. You want to refuse unreasonable demands. The patient is telling you he wants to date you. You want to refuse that. You want to explain restrictions on their behavior and reasons so the client does not feel that they are rejected. You also want to communicate using a firm, consistent approach. So the staff must be consistent. Each and all of us must agree this is what the rules are, and everybody must enforce it so that one nurse doesn't look the good one and the other looks the bad one. You want to remain non-judgmental. We also want to avoid long, complicated discussions. We must always try to meet the client's physical needs. You want to meet their nutritional needs. Encourage fluids. Offer water to them every hour because the client will not take the time to drink. Give high-calorie finger foods and drinks that they can carry while they are moving. You can give them cupcakes or sandwiches. We also want to serve meals on trays in the client's room when they are too stimulated. So let them remain in their room when the hyperactivity is on the high. Encourage the client to rest. We also need to supervise bathing routines because the client can go into the bedroom and start playing with water, or is even too distracted to clean themselves. So you want to supervise bathing routines. And we'll need to administer medications like our mood stabilizing medications. For example, our lithium carbonate. Again, lithium is a mood stabilizer medication that works in the brain. We use it for bipolar disorder. Again, our normal lithium levels are between 0.8 to 1.2 milliequivalent per liter. You need to take note of this for the NCLEX. One of the most commonly early signs of lithium toxicity is nausea, vomiting, or diarrhea. So again, your patient has bipolar disorder and you begin to witness nausea, vomiting, or diarrhea after he started his medications. That could tell you the patient is exhibiting signs of lithium toxicity. For these clients, our priority would be to instruct them to drink 6 to 8 glasses of water daily, and also to maintain an adequate intake of salt to prevent lithium toxicity. So you must take note of that. Drink 6 to 8 glasses of water, have an adequate intake of salt, and that would help to prevent lithium toxicity. On this slide, we're going to look at the extrapyramidal effects of antipsychotic medications you must know for the NCLEX. Extrapyramidal function refers to motor coordination, motor control, including being able to not make movements we don't want to make. So these antipsychotic medications commonly produce extrapyramidal symptoms as side effects. These extrapyramidal symptoms are also called drug-induced movement disorders, and they describe the side effects caused by certain antipsychotic medication. So what are the symptoms we'll see if our client is having these extrapyramidal symptoms? You would notice tardive dyskinesia, there could be Parkinsonism, there could be neuroleptic malignant syndrome. So let's break down each of these. With dystonic reaction or dyskinesia, what are you going to see in your client? you will see this intermittent, spasmodic, or sustained involuntary contractions of the muscles in the face, neck, trunk, pelvis, extremities, and even the larynx. So there's that intermittent spasmodic contractions of these muscles. What's our treatment for these patients? The most commonly available drugs in the emergency setting for the treatment of acute dystonic reaction would be to give diphenhydramine or benztropine. So again, you need to take note of that for the NCLEX. For dystonic reactions, we want to place our client on diphenhydramine or benztropine. With tardive dyskinesia or tardive dyskinesia, is a condition that affects the nervous system and is often caused by long-term use of some psychiatric drugs or even neuroleptic drugs that are used to treat psychiatric condition. So with tardive dyskinesia, you will see your patient having those repetitive involuntary movements such as grimacing and eye blinking. So again, tardive dyskinesias are involuntary movements of the tongue, the lips, the face, the trunk, and extremities. What are medications that could cause our clients to have this condition? One of them would be chlorpromazine. There's also haloperidol, which we already talked about, and flufenazine. These are medications that most commonly cause this disorder. You also need to note that treatment with metoclopramide can also cause tardive dyskinesia. So we need to stop or taper off these drugs that might be contributing to this involuntary repetitive movement, or what we refer to as tardive dyskinesia. With neuroleptic malignant syndrome, this is a life-threatening neurologic emergency that is associated with the use of antipsychotic or neuroleptic drugs or agents. What are the common symptoms you would see in clients with neuroleptic malignant syndrome? The most common ones are referred to as the NMS tetrad. So there could be mental status change or changes in mental states. Again, remember on the NCLEX, you're not going to see mental status change. They're going to tell you the patient presented with agitation, the patient presented with drowsiness, the patient presented with confusion. So again, mental status change will be one common symptom you will see with neuroleptic malignant syndrome. There could also be high fever, very high fever, or hyperthermia. You would see rigid muscles or muscular rigidity. And there would also be autonomic instability or autonomic dysfunction. This is a condition in which the autonomic nervous system does not work properly. So again, you may see the affectations in the heart. So the client can come with tachycardia or rapid heartbeat or blood pressure abnormalities. So you could see issues in the bladder and intestines. You could notice excessive sweating in these clients, problems with the pupils, the blood vessels. They can have trouble swallowing or even tremors. So like we mentioned, NMS is characterized by mental status change, muscular rigidity, hypothermia or fever, and autonomic instability. And for these clients, medicines that we could use to treat NMS would include drugs that help to relax tight muscles, such as dantrolene, or we can even use drugs for Parkinson's disease. Remember, this is going to help to make the body produce more dopamine. So an example would be amantadine, or simetril, or bromocriptine, or what we refer to as Palodel. With obsessive compulsive disorder, you would see these unreasonable thoughts and fears or obsessions that lead to compulsive behaviors. So OCD often centers on themes such as fear of germs or the need to arrange objects in a specific manner. So for example, you see the hand washing, continuous hand washing, it's dry the hands. Again, that fear of dirt, fear of germs makes him to have this obsession to keep washing his hands. So he's back to washing his hands over and over again and continues with that obsession. So again, in these clients, there will be fear of contamination or fear of death. They keep having this difficulty tolerating uncertainty, needing things orderly and symmetrical. They keep having these unwanted thoughts, including aggression. So what's our plan for OCD? The psychotherapy of choice for treatment of OCD is exposure and response prevention. In ERP therapy, people who have OCD are placed in situations where they are gradually exposed to their obsessions, and they are asked not to perform the compulsions that usually ease the anxiety and distress. We can also use SSRIs like our paroxetine and Zoloft. So these are also very effective treatments for OCD. With anorexia nervosa, this is an eating disorder causing people to obsess about weight and what they eat. Anorexia is characterized by a distorted body image with an unwarranted fear of being overweight. So in these clients, you're going to keep seeing symptoms like anemia because they are not eating as they should. There's nutritional deficit. You will see amenorrhea, which is A would be an absent. A is a prefix for absent. Menorrhea, menstruation. So there will be absence of menstruation. So this client will be missing one or more menstrual periods, and they will engage in excessive exercising. They will induce vomiting, and they will also suffer electrolyte imbalance. So for these clients, you want to monitor their status, monitor their hydration status, monitor their electrolyte levels, especially with potassium. We can engage them in family therapy, and we could also go into a contract with these clients to avoid all of these behaviors. With bulimia, this is a serious eating disorder that is marked by binging, followed by methods to avoid weight gain. So again, they consume unusually large amount of food in one sitting, and they start having this feeling that that eating behavior is out of control. And then they start looking for methods to avoid weight gain. It's a very potentially life-threatening eating disorder. So people with this condition, they will binge eat, then they will take steps to avoid weight gain, most commonly vomiting or purging or excessive exercising or even fasting. So when you assess this client, what do we see? They might actually be of normal weight or they could be overweight. If you look at their teeth, you would see erosion and decay in their tooth. They would have GI bleeding. You would notice use of vomiting, laxatives, enemas, diuretics, or even weight loss medications. And if you look at their knuckles, you would see these bruisings. Their knuckles are bruised. And this is what we refer to as the Russell sign. So this is caused by repeated contact of the incisors to the skin of the hand that occurs when they try to self-induce vomiting or try to stimulate the gag reflex at the back of their throat with their fingers. So their tooth keeps bruising their knuckles. So that's what we refer to as Russell sign. As part of our plan, you want to manage this client with antidepressants. We want to carry out nutritional assessments. And again, we want to counsel this client. And last but not the least will be manipulative behavior. Again, when you are being manipulated by someone, you are being psychologically coerced into doing something you probably don't really want to do. So again, the nurse must be conscious of his or her patient that has this manipulative behavior, because how are you going to identify these patients? You would notice that they keep making unreasonable requests for time, for attention, or even for favors, and they divide staff against each other. They attempt to undermine the nurse's role. You would notice that they intimidate others. They use other people's faults to their own advantage. They make others feel guilty. You would even notice that they use seductive and disingenuous approaches. They kind of make personal approach with staff. You know, they kind of act more like friends rather than clients. You would also notice that they frequently lie and also try to rationalize their behaviors and actions. They take advantage of others for their own gain, and they may behave in helpless manner. They can feign illnesses to avoid certain tasks. We're going to end today's discourse with this NCLEX styled quiz. The nurse is performing an admission assessment and notes that a client has been prescribed metoclopramide for a prolonged period. The nurse should immediately call the primary healthcare provider if which signs or symptoms were then noted by the nurse. Again, you want to use all 5 steps of the decision tree. What's my topic? I'm going to focus on the topic of the question. And for this question, my topic is going to be about this prolonged metoclopramide use. Again, we're looking out for symptoms or adverse effects as a result of this prolonged use of metoclopramide. And I'm going to ask myself in step 5, is dry mouth an adverse effect of prolonged metoclopramide use? It's not. I'm going to eliminate it. Is anxiety an adverse effect of prolonged use of metoclopramide? I'm going to eliminate that. It is not. Is excessive drowsiness an adverse effect of prolonged metoclopramide use? It's a mild side effect, actually. That's not going to harm this client, so I'm also going to eliminate it. Is uncontrolled rhythmic movement of the face and the limbs, is that an adverse effect of metoclopramide use? Yes. Remember we said if the client experiences tardive dyskinesia, what are you going to see? There will be that uncontrolled rhythmic movements of either the face or the limb. The nurse needs to call the primary healthcare provider because these adverse effects may be irreversible. The medication needs to be discontinued and no further doses should be given. And option D would be my correct option.